The first in-person SEOW meeting since February 2020. Here, here. It's April 4th, 2023, for the record. Welcome everyone. We have an interesting set of conversations today. If you look at the agenda, what you'll see, and I want to acknowledge Greg. I see you on the, thank you for joining us. Greg is our one of our PEB representatives. We're going to be talking about an update on MODA's behavioral health program, their access program. We have had over this past year some innovative ideas that Mercer has brought forward to us, and it was pretty clear that there was work that needed to be done. So we're going to spend some planning time trying to figure out what it's going to take for us to have be able to give the board a chance to make a decision on these concepts for the 24-25 plan year. And then the final part of our conversation is going to be talking about performance measures for our dental program. So with that, we have the synopsis from the February meeting. Any questions or additions to that? If not, a motion?
A motion to accept.
Second.
All right, all in favor?
Aye.
Aye.
Great, approved. Okay, we're on to an update on MODA's Behavioral Health 360 program, and please come on up. Is there a way to bring maybe some chairs? Yeah, why don't you just join us right here?
Be the front.
We have Dan and Erica that are going to take us through this.
Great. Well, thank you guys. It feels wonderful and weird to be here in person, but it's really great to see everybody's faces. Some of you guys I haven't seen in a few years, so it's really nice to be here today. We're going to be providing an update on our Behavioral Health 360 program. This program was implemented for OEB on October 1st of 2022. So we have a few months under our belts now. And the program came about really as we were looking at really the crisis that we've been in since the pandemic in behavioral health, and really looking to provide access for our members, and then also change the way that we're engaging with our providers around behavioral health as well. So I'm going to pass it over to Dan, and he's going to take us through first just an overview, a reminder of what the program is, and then an update on the utilization of the program so far. Dan?
Thanks, Erica. And thank you all for having us here. I'm really excited to share our progress report with you on the Behavioral Health 360 program. And I also want to acknowledge my appreciation for OEB for being such a good partner going way back in terms of really pushing the boundaries of our behavioral health coverage and expanding access, expanding benefits for behavioral health services. You've been a great partner in that respect, and very appreciative of that. So let's go ahead to the first slide. Just to set the stage a little bit more detail in terms of why did we do this? What we've seen really since the expansion of Obamacare in 2014 and an expansion of mental health parity across all lines of business is increasing demand for behavioral health services. And when I got into the insurance industry a long time ago, there were lots of providers, and you could get somebody in to see a provider very easily, and you could be selective on your panels and all that kind of stuff. Well, the demand has outstripped the supply, as I think many people are aware of. The legislature certainly acknowledged that, putting, I think we're up to about $1 billion extra into behavioral health services to try to catch up and meet the needs that are out there. And one of the key effects of that is it's become very difficult for people who are seeking behavioral health services to actually get into them. And this was true before the pandemic. One of the things that's driving that is that the supply, if you will, of providers is extremely fragmented. Whereas in medical services, you have these huge hospital systems and healthcare systems, and you've got nice large clinics. In behavioral health, you've got a few large clinics and then thousands and thousands of individual practitioners or onesie-twosies. And so for a consumer seeking services, that means I get on the phone and I call 50 different people. And that, from my experience, personally trying to help people find services, it usually takes about 20 calls to find one person who's got availability. And I kind of know who to call. This is a shortage that is, it's not just Oregon, it's acknowledged across the country. Another issue with the world of behavioral health services is that we're kind of in the 19th century in terms of adoption of best practices. And there's a lot of variability in terms of the quality of services that are provided, and we have poor visibility into that quality, poor visibility into who's providing good services, who's of the members that we're trying to serve, who's getting better, who's not getting better, and so there's hasn't been the level of transparency and accountability that we really want to see to make sure that we're meeting the aim of helping our people get better. Let's go ahead to the next slide. And that was pre-pandemic. And the pandemic, of course, made everything worse. Triple the amount of people reporting with a depressive or anxiety disorder is up to about 30%, I think. I haven't heard that it's really come down much from that. Increase in suicidal ideation, drug overdoses. So really exacerbated those needs. And in addition, as with so many things, the people who are most vulnerable to begin with were hit the hardest. And so this also exacerbated racial disparities and ethnic and socioeconomic disparities. So pretty grim picture we're walking into. Let's go to the next slide. I think many of you have probably seen this slide. And what happened was in March of 2020, an overnight transformation of the way that behavioral health services are provided. The bottom three lines are medical services. They went up, spiked in telehealth, and then came back down by June or July of 2020. Behavioral health services continued to be provided about half, anywhere from 40 to 60% through telehealth, and that continues to this day. It will be interesting to see with the public health emergency lifted, some mask mandates are going to come down. That might bring some more people back into the office, but this dynamic is here to stay for a number of reasons, that a large proportion of behavioral health services are going to be provided through telehealth. Next slide, please. So the experience of people seeking services is, maybe you have an acute need, maybe a crisis. So you go online, you go to our wonderful Find Care website and find your top 3 providers, and you call them, you can't get an appointment. You call customer service, they give you another 8 providers, you can't get an appointment. You call your PCP, you call everybody you can think of to try to get an appointment. In that space, a lot of people just give up. They get frustrated. If you're already depressed and you're already anxious, it's not easy to persist in that. In some cases, those calls would get transferred to my department, behavioral health, the clinical team, and we would be able to pound the pavement on somebody's behalf. But we weren't able to do that for everybody. And so the resolution is really unpredictable. And then again, even if you do get connected with services, it's a little bit of a crapshoot in terms of how effective those services are going to be. Next slide, please. So we designed a program to address that whole scenario. A key component of that is the behavioral health champions. They sit at kind of the middle and the beginning, so that when a person is seeking services, they can call or email a behavioral health champion. We'll typically walk through a brief assessment with that person, screen for acute suicidality or risk, find out, what their need is, what kinds of services they're interested in. We have a number of specialty programs besides the ones I'm going to be talking about that are great with individual types of situations, whether it's eating disorders or obsessive compulsive disorder, substance use disorder. So that champion can get that member hooked up with a provider. Key component of this is that we're going to verify the availability of that provider to see that member before we give that member that provider's name and number, so that member isn't going to experience that frustration in seeking services. Another key piece of that workflow then is, after the member has that first appointment, champion follows up with that member to find out, was this a good fit for you? Were you comfortable with this person? Did it work? Did things work out? Often, just the person isn't going to connect well with a particular counselor. It may just be a matter of style, but that is a key indicator of whether services are going to be successful or not. And so if you can intervene at that point, if it's not a good fit, and get that person into the right person for them, then they have a much better chance of progressing in their treatment. And then 4 to 6 weeks after that, they follow up with the member again, just to make sure things are going okay, anything else that you need. And if things are going great, then they'll close out the case. If not, then that gives us an opportunity to intervene once again and find out what's missing or what could be working better for that member. So champions in a central role there. Another key element of this is a trio of vendors that we brought in, which we consider to be really best in class in each of their fields. First of all, was Spring Health. With this boom of telemental health, all kinds of these telemental health companies have sprung up. And if I had time and a better memory, I could probably name a dozen of them. But Spring Health responded to an RFP that we put out regarding outcome-informed care or feedback-informed care. And they demonstrated that their approach to treatment is integrated, it's thoughtful, it uses best practices, it uses that real-time information from the patient to help drive treatment and make sure that treatment is effective. I'll talk about each of these vendors in a little bit more detail in upcoming slides. So move on to Gemini, which is discrete video modeling for children with developmental disabilities. Hazel and Betty Ford, best-in-class provider for substance use disorder services. So these vendors are a second key component, and then the third key component is value-based reimbursement. So having acknowledge that my field is kind of behind the times, we want to incentivize providers to get up to the place where they're actually using best practices. And so we'll talk about that value-based reimbursement model as well. Okay, so here's the new workflow that takes place of the old one, where the member is frustrated and has to make all those phone calls. They identify that they've got a need. They're able to contact a champion, go through that screening assessment. Champion is either able to get them scheduled online right there, or champion then typically they'll start pounding the pavement for members for whom that's not the best approach. Find that appointment for the member, get them connected, confirm that connection, confirm it's a good fit, and then do that follow-up after 4 to 6 weeks. Next slide, please. So I've asked the champions to send their supervisor, Renee, and me emails of the feedback that they get. And I mean, it's worth it coming to work just for these things. We get them quite a bit. I like this one in particular. Thank you so much for following up. Treatment has been helping immensely. I can't thank you enough for helping me when I felt like no one was. And that is very representative of the kind of feedback we get. And I also like it because this quote sort of shows that whole arc of seeking services and then following up afterwards. Next slide, please. Okay, our vendors. Spring Health, I mentioned that we found them to be a best-in-class provider. They've got a very integrated ecosystem. They're able to provide mental health therapy both virtually and in person. The in-person services are fairly limited at this point, so we primarily are using them for folks who will say that, yeah, I'm comfortable with a virtual or telehealth approach. They also offer psychiatry, which is a great service. They don't prescribe controlled substances, which I think is wise on their part, but also is a limitation in terms of the needs of some members. They have licensed care navigators who sort of watch in the background in terms of the person's progress and what they're needing. If suicidal ideation, if there's a red flag for that, they contact the member within 2 hours and make sure that that person's safe. So they've got a really tightly integrated system. And their access is incredible. Day and a half on average. They've got a large number of languages that they speak, LGBTQ plus providers, large number of BIPOC providers. So a very comprehensive and thoughtful approach to services. They've been a great partner so far. Looking forward to continuing that. Next slide, please. Gemini is the Spring Health, there are generalists. Gemini is very much a specialist for children with autism spectrum disorder or other developmental disabilities. And it provides discrete video modeling, which helps the child learn both language skills and behavioral skills. They've got peer coaches that help the parents navigate how to use the program, navigate systems. Kids with developmental disabilities tend to be very systems involved. There's a hope that that this could decrease the hours for applied behavior analysis. We don't have enough data on that. It's going to be a difficult thing to really prove, but I do think it can substitute for some of those services, and also provide an option for folks in rural areas where those in-home behavioral health or ABA providers or other providers just don't exist. Next slide, please. Hazel Meddy Ford has been a great partner for us since we initially contracted with them in maybe 2014 or 2015. They created a resource website that OWEB members are able to link to from the OWEB public page or from their Moded dashboard account. Provide extended coaching and case management, family education and support, and they also have options for providing employer training. Next slide, please. Okay, so at risk of starting to repeat myself a little bit, but the champions, helping members to understand their treatment options is super important. Their knowledge of the Moded network is super important, and they're being embedded within our behavioral health team is super important. So they've got access to our licensed care coordinators, our case management team. They get to know the providers in our network and are able to really get members slotted into the place that's going to be most effective for them. Next slide, please. So as of mid-March, they'd served 245 OWEB members. 62 of those had begun services with Spring Health. 116 had begun services with other in-network providers. So again, there's that broader reach. Spring Health is an incredible partner, but they are a partial solution.
And that's starting from October 1.
Starting from October 1, yes. when they did those follow-up calls with members, 87% of them reported they were satisfied with their provider. And there were few enough of the ones that were unsatisfied. I was able to actually go in and look at the cases, and 4 of them had gotten engaged with another provider. Another one's like, "Oh, I'm doing better. I don't need to continue." And one actually was like, "I had an issue with this provider and we got it resolved," which is the ideal outcome too. Next slide, please. So this is just kind of interesting to see the contacts by month. Started out a little bit slow in October and has peaked around December and has declined a little bit. Some of that is driven by our campaigns. We have another campaign going out this month, which I expect will drive the utilization back up again.
I didn't understand this because you said 245 were served from October, and then I saw this slide and added it up, and obviously it's more than 245.
Right, because that reflects multiple contacts per member.
Got it. Okay.
Yeah, that's that initial contact and as well as the follow-up contacts. Next slide, please. So Spring Health, just zooming in specifically on them,
And the question that I had
Yes.
for Erica was, the 245 members were served during that 5.5-month period of time. That's the numerator. What's the denominator of people accessing behavioral health services? I'm trying to get a sense of, for the behavioral health champions, are they dealing with 5% of the mode of membership that's seeking behavioral health? Is it 50%? Where it's well under 50, and actually that's partly demonstrated here. So we had, because Spring Health has done direct outreach as well, a lot of folks went directly to Spring Health via that outreach. So they actually had 440 people who actually made an appointment without. Well, some of those were through a champion, but a lot of those were not. Then there's also people who are reaching out just on their own still. I don't have the numbers yet, but we will. If you get that to me, it'd be helpful just to make sure we, if the behavioral health champion may be an important component, but if it's dealing with 10% of the people accessing behavioral health, it's a small component.
Gotcha.
It's not the solution. And I'm trying to understand what that whole sphere looks like.
Yeah, and I think it'll be important to look at that after we've had more run out time.
I'm fine with that time too, with it. It was just a question that came up when I saw those numbers.
Yeah, there's definitely still, folks out there. Part of it is the importance of getting the word out.
Sure.
And continuing to work on that.
Dan, is it MODA's intention that every behavioral health care member would run through Behavioral Health 360, or just some types of behavioral health members, maybe more acute or more complex?
As many as we can get. I mean, if somebody's able to access services on their own without difficulty, I have no issue or reservations about that. We're here, the champions are there because we know it's difficult in general. And so we want everybody to have the opportunity to have that access without any barriers. But again, like if they go directly to Spring Health, got no issues with that.
But if they went through the Behavioral Health 360 program, we'd have the opportunity to collect more outcomes metrics, maybe.
Follow up and things like that.
We're getting good outcomes metrics from Spring Health as well, or we will be. We haven't gotten our first 6-month report, but I'll show you some data on Spring Health. The outcomes we don't really have quite yet, but we will have that quite soon. Thank you. Okay, next slide, please. And so this just is a sort of an interim report that we got from them. So they are meeting the access that they were promising. They've got availability within 1.4 days. good availability as well for prescribing providers, good availability for kids. There's certain threshold at which for younger kids, telehealth isn't necessarily the greatest thing. So those are some of the folks that will be in some cases sending elsewhere. But again, access is looking really good through Spring Health. Next slide, please. And significant distress among the folks who are accessing the Spring Health services. So the majority of those folks reporting significant symptoms of anxiety and depression, as well as surprisingly high occurrence of eating disorder, as well as other conditions. Next slide, please.
All right,
Okay.
so I'm going to take over for the next few slides. So Dan has told you and given you an overview of the program and given you information on utilization of the program so far, but it's really important that members know about the program so that they can engage with it. So I just want to give a quick overview on what we've done so far and what we are doing to reach members. So one of the really cool ways that we've been trying to reach members is through our new Moda 360 member dashboard. So we launched a new dashboard for Moda 360 members at the end of January. And this new dashboard is it's enhanced, it has an easy to use layout, so it's easier for members to navigate, find what they're looking for. And it's very pretty as well. And it's also personalized to each member. So I could talk about the new Moda 360 dashboard for well over an hour, but I won't. It's really interesting, Tom. But I'm just going to talk about where it pertains to behavioral health and the behavioral health program. So next slide. So one of the ways the new dashboard is personalized is through our programs. So for every member, we take all of the information and data that we have on that member. That includes their claims data, any other data we have, as well as SEOW data that we've gathered on the member. And then we run that through our health context, which comes up with a health context score. That then feeds into what we call our personalization engine. And that personalization engine runs up against all of the programs that are available to members. That includes programs that are from OWEB, as well as programs that are from Moda. And it takes all of that data, and then it picks the top 3 programs that we think the member could benefit from the most. So in this example, this member these are the top 3 programs for this member. The first one that comes up is the C3 program, and the C3 program is an invite-only program. So you won't find this program listed on our website or listed on OWEB's website because you have to be invited into the program. The goal of the program is to get members connected to a quality primary care provider, so PCPCH. And then when they do that, they have their PCP office visits waived and their mental health office visits waived. So this person probably received a letter in the mail, may have received a call, didn't respond. So now it's showing up in their member dashboard here. The second one is SiriusMD. If the member clicked in here, they'd be able to click and go right to the SiriusMD website to register and enroll. And then case management as well. This is also another invite-only program. So this is showing up for this member only because they are eligible for the program and we've invited them into it. They could click on this and it's going to give them the email and the phone number to be able to connect with the program. If we had data on the member that showed that they were at risk for depression or anxiety, and that data could include a diagnosis on a claim, or it could include maybe they've completed our SDOH form that's available on our member dashboard and is also something that our navigators will work with members on as well if they're coming into a program. So if they've indicated on that form concern around behavioral health, then Spring Health or the Behavioral Health Champions might come up to the top as one of the personalized programs. So, but if a member comes in here and they want to see all of the programs that are available to them, so to find the behavioral health programs, they can click on the View All Programs link at the bottom. There are other ways to get there, but from the personalized programs, that's how they would get here. So next slide. And when they do that, it's going to bring up a list of all of the programs. Like I said, all the OWEB programs and all of the Moda programs, including the ones that they're eligible for. Members can search for the type of program that they want. So here, if you notice on the left under category, I've selected mental health, behavioral health. And so all of the behavioral health programs come up here. So Spring Health is that option right up there at the top. The behavioral health champions are next to it. So if the member clicked on the behavioral health champions box, it's going to give an overview of what those behavioral health champions do. And then it's also going to give them the email and the phone number for the behavioral health champions. Let's say a member was specifically looking for Spring Health. They can click on that first box, Spring Health. So next slide, please. Then it's going to give them information about what Spring Health is. And then if they clicked on the Learn More and Enroll, it's going to take them directly to the Spring Health website so that they can register and engage with Spring Health if they choose. So that's one way that we're trying to get the word out and making it easy for members to be able to find the behavioral health programs and just all of the programs that are right for them. If we go to the next page, we've done a lot of other things to try and get the word out as well. We've mailed letters and flyers and emailed those to members. And every time we send out a mailing to members, we send that same communication to all of the entities. And a lot of times those entities will take that information and they may email it to all of their employees. They have email addresses for all of their employees. We only have it for some OWEB members. And a lot of times when members see a communication come from their entity, they may be more likely to pay attention to it versus when MODA sends them something. Spring Health, as Dan had mentioned, also has done mailed and emailed campaigns to members. We also have information on the Behavioral Health 360 program available on our website, which is modahealth.com/OEBB. And there's actually a behavioral health tab on the left-hand side just to kind of call it out more. And when they click on that, it takes them to a specialized Behavioral Health 360 program page with all of the information and the links there as well. And then we provide materials to entities prior to open enrollment meetings and benefit fairs. As soon as the board votes and makes all the decisions, we usually reach out to entities and just see if they'd like to do a virtual or an in-person meeting where we just kind of go over the changes and an overview of all of the programs that we offer for members. So at those meetings, we'll bring flyers. Spring Health is also giving us some posters and flyers to bring to the entities this year as well. And then at the open enrollment benefit fairs, we have information on the behavioral health program as well. So that's how we're trying to get the information out to the members as the best that we can. Next slide. Great. Any questions on member outreach before I?
You've got 5 minutes.
Perfect. I'll pass this over to Dan to talk about how we're changing the way we work with our providers.
Thanks. Okay, next slide, please. So value-based reimbursement is hard enough for medical, and it's even harder for behavioral health. One of the reasons is that extreme fragmentation, attribution, all these kinds of things. But we've dived into it and we're very excited about it. One of our first steps was hiring a new position that we call clinical liaison. And this is somebody that comes to us from a clinic that we worked with closely for a long time. He was a director there, as well as a clinician, very steeped in outcome-informed care, feedback-informed care, gave trainings to their employees on it all the time. And he's as passionate about it as I am, which is awesome, in my view. And then there's 2 components to the value-based reimbursement program. One component is a total cost of care. This is building on our belief that effective behavioral health care is going to have a desirable impact on our overall trend. It's going to help people take better care of their health and push things towards the preventive rather than the acute side. So there's a cost of care goal of maintaining within 5% trend. And if as a whole, that says 2 regions, we actually combined it all into the whole state of Oregon. If we achieve that target, then providers will get a 2% bonus from all of their reimbursement from the year. The other portion of that is outcome-informed care, also known as feedback-informed care, where we're asking providers to use the measurement tools, talk to us about how they're using them in their clinical program, report to us on that, and coordinate with our champions. And really, this first year is a let's I don't know if we're crawling or walking in our first year, but we're moving in the right direction, and engaging with providers to be interested in this kind of value-based reimbursement. Next slide, please. So as I said, so it's up to a 6% incentive payment, 4% just to participate. If you sign on the dotted line, say you're doing this outcome-informed care, and you'll report to us on these basic factors about how you're using it and work with us around that, that's 4%, and then 2% that they will or will not earn sort of collectively based on total cost of care.
What's the uptake so far in terms of like the participation rate for this?
Let's go to the next slide to address that. So it has been somewhat disappointing, but also encouraging. We have some of our, some key partners that have engaged. We've rolled this out to providers who have at least a critical mass of members in order for it to be meaningful. So LifeStance is one of our largest providers. American Mental Health Association of Oregon is a really interesting one because they're actually an IPA. So it's a totally different service model, but they're able to bring a certain mass of providers there. So we've got.
And Spring Health is not on that because you have a different relationship.
Because we have a different relationship with them, exactly. So a little more than half a dozen there, I think, of either confirmed or likely to be participating this year, and we're still out there pounding the pavement. Next slide, please. All right, just to wrap it up. So Ashley did a follow-up call. It's the first time in a while she's hopeful to get the care she needs. Again, we very common refrain, and keeps us going.
How much time do you have left?
We have now time for questions and comments. So I was going to ask you to, and the rest of the SEOW members to jump in.
Well, thank you. It all sounds really good. My problem is either I'm really dense or I don't fully understand the subject well enough to know how all this fits together. What I mean by that is my understanding of completion of care is when the patient senses that they have arrived at a healthy state.
Mm-hmm.
How do we measure that? It's kind of like your fever is gone, check, if you go to a primary care, or you've removed a tumor. But the subjectivity that comes across to me on behavioral health is, how do we know when we've given enough care? And so all this sounds good, but that baseline understanding kind of eludes me.
Yeah, well, you're not alone in that respect. There are, I'm going to exaggerate here, as many different ways of looking at that as there are clinicians. There are clinicians who inherently have a long-term orientation. We're going to work through all your issues, and clients who want to go there. There's clinicians who are much more like, okay, let's get a problem solved, and once you're doing better, let's move you on. There is, unfortunately, no uniformity in our field around how you approach that. The practice of measurement-based care or outcome-informed care moves us a little bit in that direction, because what it does is it's your thermometer, right? We can see that your fever has come down. That allows for us to have a conversation then that otherwise we might miss, because you come in, you're talking about the thing that happened with your best friend or your partner or whatever. With that kind of a common denominator of we're able to measure your symptoms, then we can have your depression is down into the non-clinical range. How are you doing? Do we have more work to do here or not? Not all therapists are going to approach that the same. And so it's the Wild West out there.
So how I guess my concern is, and I may caveat, maybe misunderstanding, when we get into value-based care, it seems like there's a danger of kind of pushing people out the door maybe prematurely. And I know we can't solve this in the next 30 seconds.
Yeah.
It's recidivism, right? How often does that patient have to receive more help later?
Yeah.
Which was my experience, not me personally, my daughter. Right?
Yeah, so there is that flip side of that is using measurement-based care, using feedback-informed care can alert you to when somebody is deteriorating. And that's actually one of the key benefits of it is like, oh, wow, this is not going in the right direction. Let's talk about what needs to happen differently. It's the goal is not to push people out the door, but to have an objective sense of how are we doing.
I think, and I'm going to take the analogy in a way is for on the physical health standpoint is readmission rates or reoperation rates.
Recidivism, yeah.
Just as Bill is saying. So it would be helpful as you build this, your value-based system out, is to start trying to figure out what are those measures that show that care is incomplete. Now, the reality, just like in the physical world, in the behavioral and mental health world, there is recurrence. So, you know, and there's some that are just plain old chronic, meaning that they're present all the time. So that is the complexity of human beings, but trying to get at what Jeff is raising, that would be an interesting, if you can take it back to your team and say that SEOW at least is interested in, you know, as you move forward in terms of outcome measurement, is to also look at the balance between you're done, are you really done, you know, what are the quality metrics that would keep people from moving too fast, being moved out too fast.
Well, I appreciate hearing there's some measurement tools emerging, because sometimes the patient needs to hear you are getting better.
And that can be powerful in itself, particularly like with depression. I didn't even realize that, but now that I see this and we're talking about it. Yeah. Another super important piece of measurement-based care is measuring the relationship. So a good measurement tool is going to say, how well did I attend to you today? Did we talk about the things that were important to you? Are we working, you know, are we working on the things that you want to work on?
Well, thanks for indulging me on all that.
No, helpful. No, that was very thoughtful comment and one that I thought advanced it. Jeff, thank you very much.
Yeah.
Other comments from, because we're at near our end, but please, Robert.
Okay, this is regarding utilization of the behavioral health champions. Now that you have a benchmark, what would success look like at the year point, and then what would success look like 2 years out?
Mm-hmm. You don't have to answer that now, but that's something to bring back to us.
Sure.
Okay,
Will do.
we'll definitely do that.
Because we have a couple follow-up issues that from this that will have you bring back. Maybe in September, you'll have more data, but understanding, addressing that specifically, what does success look like, and then how are you measuring it? That would be really helpful.
Great. And one thing I just want to add as we're closing and really going back to what Dan said, but with the value-based payments, this is all brand new. And yeah, and we really appreciate OA really coming on this journey as we really look to transform the way that we're engaging with our behavioral health providers.
Very much.
Bill, do you have any comments that you?
Maybe a comment. I was just thinking, because we're doing a lot of work with equity and unconscious bias, and some of the scientific surveys that are created to extract your unconscious bias into data is quite fascinating to me. And I'm wondering if there's similar kind of things for depression and for teenage work, especially. Is there science behind that? Is there work that actually does that, just like we do in the other science I'm doing?
That looks for unconscious bias? Or?
Well, yeah, like that, you know, where these people, psychiatrists have come up with these surveys that actually tease out of you your unconscious bias without you even realizing it until you see the results of the survey.
I don't quite fully understand the context of the question. Sorry. It's just-
So it's a Harvard study kind of.
Yeah,
thing,
yeah,
but we don't
right,
have to
right,
get into this.
right. Yeah, like that where
So,
you're
yeah.
clicking, yeah.
Maybe at the break, you do
Yeah.
can.
Okay, thank
So
you.
thank you very much. That was great. We are now changing gears and are going to be talking about the projects that Mercer brought to us over the last 6 months. And the idea here is for us to time out how we're going to start addressing these issues so that we can actually bring them to the board. So,
That's great, thanks, Tom.
Susan, you're on.
Yeah, that's perfect. We have two.
I'm sorry, is there coffee over there?
Yes.
So I'm gonna take a 20-second.
There's also water.
Thank you very much. Yeah, I really appreciate it.
We can maybe just turn our chairs and see the patient this way.
Thank you so
You
much.
go ahead and start. I'm listening.
Maybe sit.
I'm good.
So the intent was to capitalize on the opportunity to all be in the room together, to collaborate on a couple of the items that came through the clinical process this spring with the renewals. And they were items that we all decided, hey, this warrants further conversation, but it's complex and we want to do it right. So let's not try to shove it through for 10/1/23. Let's take an opportunity, spend some time really deciding what's best for OEB and when, and then we'll bring it again to the renewal for 10/1/24. So those two items, they're a little bit different in scope. So the conversations will be a little bit different as well. The first one of those is doula coverage. And really the question there, this is an implementation problem. So how do we implement doula coverage? And there are some operational questions we'll have to work through with the carriers around licensing and reimbursement and how does it all work? And we'll bring PEB on our journey with us on doula coverage as well. So the idea is to use our time here together to understand what a work plan would look like. Do we want to make a work group and who would be on it? What timeline are we shooting for? How does SEOW want to be involved with the work plan's progress, or do we want to do it all in SEOW? So those will be some questions related to doula coverage. The second question, or the second topic, really is around metabolic disorders. So that was the idea where starting all the way on the left with the left, on the preventive care spectrum or the low acuity spectrum, you guys maybe can visualize a slide from one of our previous months. We already know we want to revisit Weight Watchers and understand the value there and the impact, and are we really providing the right solution to members with this low acuity weight loss. And then we have now Virta, Livongo, Omada, Kaiser's own programs. We have a bunch of treatment options in the middle that we want to come to alignment on, make sure we have the right clinical outcomes that we're working towards, the right goals. And then we also have in front of us this question about what do we do with weight loss drug coverage? So that's the nature of what we're calling a holistic metabolic disorder treatment strategy. It's a mouthful. So that's really the second question, is deciding, again, is this a work group approach? What kind of timing are we looking at? How does SEOW want to be involved? What should we tackle first? Because this is a more complex issue, right? This is going to be a multi-year rollout, probably not a one-year rollout. So it's different from doula coverage in that way. So, I know we have some clinicians, Dr. Popowich and also Dr. Bachman, who can participate in the work plan conversation on the behalf of the carriers, and then we'll get the SEOW committee's guidance as well. And then the third item, I do just want to touch on now, so we all kind of know where we're headed and we can fit the pieces together. We also have, well, we're coming up now on closing out this season of SEOW, and we'll be starting again. We may do some work over the summer, but the next SEOW and board season really starts in September of next year. So are there things that we know now or that we've learned over the last year that we want to incorporate into the calendar next year? Do we want to change some of the timing of items? Maybe start some of the clinical renewal things a little bit earlier? Are there items that we've heard this last year we want to make sure get on the agenda We know we're going to need to touch on chiropractic care at some point. That was an important member request that we need to look at. So different items. So we'll have in front of us on the screen, Maggie will project last year's SEOW, a consolidated list of the items that we touched on in SEOW over the last year. And we can talk about some revised timing and adding. Again, we're not writing anything in stone, right? We're just collecting our thoughts and understanding how the timing of everything fits together. So as we begin this bigger work with doula coverage and the metabolic treatment disorders, we know where we're headed. Any questions on just the general approach? Otherwise, I'd like to invite us all to start a conversation around doula coverage and what the work group or SEOW would look like.
Kirsten has outlined what we're hoping to talk about. Any comments just from the beginning? It is going to be one of the questions is how does SEOW deal with this? What is our roles and responsibilities in this, and what involvement individuals want to play in this?
I might be stating the obvious, but we're kind of guy heavy on SEOW, so I think it's possible that
I didn't notice that. I guess we are.
we might want to, if we're doing a work group, we might want to expand beyond just us four. So
the other question is, do we, as we look to add for next year, for sure, having a female presence on SEOW of a board member, and maybe you as the board, are you board chair next year, or is that?
yes, I think it will be, yes.
Okay.
I have not been reappointed yet, so I can't say for sure.
Okay. Well, if you are, we sure would like if you could then work with OEB staff to recruit female presence on SEOW. I think that would be helpful.
I heard a comment from Kirsten that is an obvious question, and I didn't realize I didn't think of the obvious question, but what in the state of Oregon allows you to be a doula? How do you get that title?
Yeah.
Right? Do you know that?
No, I don't know that. I don't know. Dr. Twain knows that.
There are certifying bodies at a national level, but I think then you get to the state level in terms of a qualified person.
Does Oregon have something that says you get to call yourself a doula?
Yeah, fortunately, we have the work of the Medicaid program to piggyback on, because doula coverage is already now being rolled out in the Medicaid space. So they're having to be on the leading edge of answering all of these questions for us.
So we would just follow that.
And our two plans, MODA and Kaiser Permanente, are doing it now. I mean, are in that Medicaid process piece.
Following the Medicaid process.
So that really will move us along.
Move us along
Yeah.
at a national level,
Yeah.
following the national
Yeah.
guidelines of.
So what's the baseline licensure that,
They're not licensed. That's been a concern going back.
That's why,
It was
once you brought it up, I'm curious
So
about this.
community health worker is the closest thing to that. That is sort of an Oregon State way of having health staff that aren't fully licensed. But that's been a problem in the hospital setting through the years, was doulas couldn't be credentialed by a hospital or
and therefore no privileges?
Right, because the training was a certification, not actual licensing. So, which the standards are less to obtain a certification than to actually get licensure by the state.
Jumping into another pathway, but just to really understand, you can't just call yourself a chiropractor in Oregon unless you have some certification or some licensing, right?
Oh, it's very clear.
or acupuncturist or
Okay.
naturopath.
Or
So
tattoo?
those things are set, but doula's not.
Tattoo artist.
Yeah, exactly. From a marketing.
Clearly licensed, well, licensing board and the whole thing.
But we don't have one for doula.
So what's the problem we're trying to solve here?
So the problem is if we have, and I think we got through this conversation this spring, if we decide that doula coverage provides a valuable service to women in improving outcomes through delivery, we want to roll that out to OEB, then there's some complicated considerations that the carriers will need to work through, and there's an opportunity to have the carriers work together in partnership with Mercer and the SEOW committee. So we develop programs that are in alignment with each other that are as similar as possible between OEB, between MODA and Kaiser, also that consider needs of OEB and PEB at the same time. So that's that collaborative aspect, as opposed to just saying, okay, MODA, go create something. For 10/1/24, we'll hear about it in February. Kaiser, go create something. And then we haven't had input along the way into that program. So we're designing something it's an opportunity to design something that's going to fit us from the start.
So one more thing, if I wrote a check for my spouse wrote a check to a doula for my spouse, could I deduct it from my taxes?
I think we have gone through that, and it does count as a healthcare expense.
Okay.
Yeah, it was part of our due diligence in the project.
So short-term memory loss, I'm old and,
Yeah, no worries. So we have at least made it through that hurdle. So it is coverable by the plan.
It is. I'm sorry to inform you, but I don't think your wife is fertile.
I don't think she is either. Let's just stop there.
Sorry. TMI, sorry.
That's hilarious. So I think one of our questions then, and we have Dr. Popowich here as well and Dr. Bachman, is how do we want to collaborate? To Tom's point, how does SEOW want to be involved? Do we want to participate directly and I'll do it together? Do you want reported updates as we go?
I'm interested in hearing from Yale and Keith about what they're, as you to think about bringing this issue forward for us, how would you like to do it? What's your vision of us being able to come in January of 2024 with a proposal? How do we get from here to a formal proposal that SEOW would look at in January of 2024 to say yay or nay for doula coverage?
Yeah, I think there's a lot of room for collaboration on this topic. We traditionally have not had doulas as contracted providers. Mostly we historically have not provided below the level of an advanced practice nurse practitioner, just for liability and the licensure requirements. But doulas have tremendous value, and we recognize that, and we've learned some of that from the Medicaid space, particularly when we start talking more about SDOH and equity. They have a very, very beneficial role in the communities for helping women, not just with the actual birth, but getting them through the whole pregnancy process and even postpartum, and having them part of a care team, I think would be truly beneficial, and we're fully on board with that.
So I know I'm walking around the bush, but doesn't that put the carrier in somewhat of a credentialing mode?
It's something that would have to be addressed. How would we credential them as part of the care team? And I think that's something we could certainly work out.
But you must be doing it now if you're doing it with Medicaid.
In Medicaid, basically the doulas just charge for their service, and we pay them as basically independent contractors. They're not on panels or anything like that.
They just have to have the certificate.
Right,
They've
they have
had
to
the
have a
training.
certificate. But I think as part of a more collaborative care team for maternity care, I think they would be extremely beneficial.
Keith, do you want to represent?
Same thing. I think it's probably a little logistically easier. I think we would be contracting. I don't think we would be bringing doulas into our maternal fetal medicine programs. So we'd be contracting with that as an added service for OEB and PEB members that want that. Same as with Medicaid. And ideally, we would be looking, I would expect us to be asked to look at outcomes, particularly in the commercial population, and see what % of laboring families choose this service, and of those percent who are satisfied with it, we could also certainly, it wouldn't be very statistically reliable, but looking for preterm deliveries, looking for maternity complications, so we can assess that out, at least report that back.
Is it reasonable then for this one to have basically to have the two of you representing your health plans work directly with Mercer and basically come back, you know, for us to set a date, and it doesn't, whether or not it's December, January, February, I don't know if that part matters, but basically to charter a work group that would be the carriers and our consultants to come up with something.
Absolutely. Sure.
Yeah. And then is there any advantage of having this group of old men? I'm sorry, he and I, old men.
There's old and then there's old, yes.
You two young men.
I mean, we would welcome your input, but we're also very happy to work with our colleagues at Mercer on this as well.
I was challenged with Lamaze, so.
Maybe there's a midpoint update. I also want to be cognizant of the fact that if we're developing this for OEB and PEB together, that we need to make sure we're bringing everybody along, all the stakeholders together in the process, so we don't get to the end and then realize we've made a decision we should have collaborated on.
So should we start this earlier than January? Because like in the fall.
Well, I want a finished product by then.
Yeah, we'd start now, Jeff. Or at some
I'm
point
talking
in the
about a
year.
finished
Just
product.
misunderstood you there. Okay.
Not started, yeah.
That's good.
Start now,
And
yeah.
for a 10-1-24 start.
Yeah, and I would love to participate if the rest of SEOW is okay with.
I have a different, and I don't know if the reason I'm struggling is I know this is an appropriate question for this topic, but in school districts, we're finding we're having to put together affinity groups for first-time moms. You know, and it's very important, and that's where they struggle also, right? And so they last for about a year or so, but.
I just need permission to access the mic to hear you.
Is that? Yeah. Somebody telling me that, no, this is not important, but, you know, and what I'm wondering if we do that in OEB instead, there's a kind of a, what I would call a semi-mental crisis with first-time mothers. And just understanding, and it's not so much reading a book, it's just being together with other first-time mothers and just being able to talk, you know, and the affinity group. So I'm finding that education districts are having to do this just to help the community, and it really should be here in like this kind of thing we're talking about. And so I don't know if I'm out of my lane or not, but that's my point I'm trying to make.
It's really solving the same problem. I mean,
That's why I'm wondering that.
Very related
Right.
issues.
I think so. So I would like to expand this to also cover like that kind of service as well, right? But I don't know if it's not part of it. I don't know. Anyhow, I'm done. Right.
More to follow.
I mean, there's a model for centering pregnancy, which is done, same idea, bringing families in together, prepartum, education, a little bit of clinical touch, and then a support group for afterwards.
When I talk to these women at school, they just like, just being able to talk with fellow first-time moms was all I needed. Right? You know, that ability.
That may be, it also may be something that we want to look at for our wellness champions to help organize, because that needs to be done. OEB isn't able to do that. We can provide resource, and but it has to be delivered at the local level.
I agree. So again, I'd like to add that to some of this discussion, right?
Okay. Other thoughts about doula? Now, we just kind of jumped your presentation, but.
No, it's great. Our presentation just consisted of a reference slide from last month
Okay.
to remind people about
What it was.
what it was if they had questions. So we're doing exactly what we hoped.
So what I heard was carriers and MODA will set a time frame to be able to get a finished recommendation to SEOW in January. Included in that would be cost implications. And yet the assumption is that this is also one where cost and quality go hand in hand. The assumption is that you improve outcomes, you decrease, and it results in decreasing cost. And it's one of the things to help, it's the board's goal of trying to move upstream. And in terms of funding it, this is again where we would be looking at RSR as the priming the pump in terms of funding it. Okay.
Just a thought, since you're bringing in the PEB board along the journey, Dr. Mottner, who is the Medicaid medical director, is the PEB board vice chair, and
Wonderful
would
to
be a
add.
valuable resource since Medicaid is going through it now.
Yeah, it'd be wonderful to add that to that work group if interested. I don't know that person, so I don't know.
She'd be interested. She's also very busy and pulled in a lot of directions, but.
Well, at least, don't let her availability keep you from moving forward, but at least keeping her in the loop in terms of all the processes as you move forward.
I'm sure there's voluminous learnings and meetings and public comments and other work that went into their work planning for this. We might as well springboard on that
Yeah.
rather than starting stretch.
Yeah, that would be the best, first month or two would be.
Anybody did a great job posting that activity too.
Yeah, this really is one of those, we could push this one forward really as looking at the whole health equity issue. One of our bigger projects, if not the biggest. Okay.
Do you do this oral then?
Okay,
Did you want to take a short break now or keep going and then break?
no, let's take a break. That's a great idea. Okay, so we're going to break for the next 10 minutes. So we'll reassemble. No,
Crumbs to get
it's
to the
pretty,
restroom.
go to the elevator. It's just right around the corner.
Okay.
It's an hour break.
10 minutes. I think we said 10 minutes. 10 minutes.
Okay, so, initially, we didn't really plan on it. And then we decided we were gonna plan for lunch, so we're thinking there's a Subway close by. And if people want to just tell us what we want, so.
We have a public comment for OLED. So and it's a letter form. So
And this is.
And it's
we just
only,
enter it into our minutes, or how does that? Because I've never done a public comment that's done that way.
I think we've done both. If it's a lengthy letter.
Somebody's done a lot
Yes,
of.
you already have, look at you.
Well, if it went out in the packet,
this was sent to
board members have already read it, you can simply refer to it.
Like Rose said it as a separate document, and I can't remember who she sent it to. So could have been just,
Oh, these are for this afternoon.
I'm not sure. So I need to go back and look at the email. So
Check that, and then we can double check with Ali. He'll be here for the board meeting this afternoon. He just got a conflict with SEOW in his interim
I
role.
think,
everybody's stretched, right? So.
yeah,
All right,
so don't worry about
they're
that.
getting paid for that.
That could have said.
And so he said that they'll just go,
I think the four of us will go off and have some mail bonding.
that's fine. Yeah, good point on the 4 old men talking about doulas.
On the whole
Hey, I
spectrum,
put
does
together
4
a
old men come
childhood-
before or after 3 blind mice?
I put together a childhood education program.
So
We're just missing Bill.
Lock the door and make him pay us to get out.
He gets the next round of
I don't
coffee.
think we're in a position of power in that one.
Just leave.
Got the afternoon off, works for me.
Okay, good.
Yeah. Let's go ahead and start. Thank you, Bill.
Great, so for item number 2, we would just want to go through a similar exercise of collaborating together on how we're going to approach this. And I did just want to outline there are different questions within long-term holistic metabolic treatment plan. And maybe we can take the pieces of that project one at a time, because I think they might have different timelines, different stakeholders involved as well. Let's start maybe in the most simple place, which is we have already decided that we want to reevaluate Weight Watchers and understand the role it plays in the treatment of weight loss. And specifically, are we getting the outcomes that OAB members deserve? Is there a different solution that should be added to the portfolio? So this is more of an analysis question, traditional report back to SEOW, and then SEOW would make a recommendation that way. So maybe the Weight Watchers aspect of this stays in SEOW and becomes a normal agenda item. We can have the carriers go and do an analysis and come and present.
We had one of our presentations that we had about 4 years ago. Kaiser Permanente was able to look at people registered with in Weight Watchers and was able to give what percentage lost, I think 5% or more body weight. And so we had, I don't know if you can resurrect that, what you did before, but it showed modest effectiveness.
Yeah, modest, I would say, is a little stronger. You could pick up some weight loss in people. But again, it wasn't a real study. It was just data out of the medical record. Some people had weights after, some people didn't have weights after. But we saw a trend towards lower blood pressure, slightly lower A1C, and a few pounds of weight loss in OAB members who took advantage of Weight Watchers.
Okay, so we have some rough data. The question is, and in terms of over the last, what would be helpful is to get a sense of, is there something better? And there, since then, there's been several new things that have gone, I think are being just offered in the market from a behavioral standpoint, Noom as an entity. I don't know what the individual plans are doing right now to help their members with weight loss. Having that type, I agree with us keeping it in SEOW. The question is just what we want. What type of information would we need to be able to recommend to the board? Yes, continue WW versus not.
Well, it seems like the first decade, Weight Watchers was our best alternative. It was outperforming the other programs that we had in. But to your point, a lot has changed. A lot more research into insulin resistance and all that. So it would be good for us to do a deeper dive and tie it in and look at alternatives now. I mean, just because they were the best option 15 years ago doesn't make them the best continuous one.
And you may find it's hard to find one to fit the population, just because we're all highly different, and then we've got cultural differences and things like that. So you're right, there's some of the science, some are more digitally enabled. So some of that we have to sort of reconcile, figure out what's going to work well for who within the OAB population. So I don't think we may not end up with just one. It may be a combination that covers the gamut, if that makes sense. Is that your experience?
I agree with you. I mean, we had like 4 programs going simultaneously about 5 years ago, and we've kind of winnowed it down because they weren't attracting much engagement. But expanding it, yeah, we should consider a multi approach. I agree.
Yeah, so maybe what we're talking about is I don't know if we devote a whole month to it or we carve out half of a month for it, but we would have carriers can come and report on outcomes data, and Mercer can provide an update on where the landscape has come in the last decade and what are the new options and alternatives out there.
Yeah. And what each of the program is doing internally.
Yeah.
Because it is $1.4 million, I think, is what we're going to be spending this year. So it's a serious.
Oprah's got enough money.
Serious money.
And, the question also is whether or not we keep it, as part of the premium package, or, we do it with, like we did before when we winnowed down, so.
Arrange preferred rates for members.
Erica, is there anything that MODA can do for Weight Watchers reporting as well? If Weight Watchers gave you a list of members enrolled?
If we got the members enrolled, so with Weight Watchers, we used to get a claim for the members, so then we could have been able to pull data about the members. Today, we don't get a claim, it comes over on an invoice. We have to see, but if we do get their e-numbers, I mean, we could definitely pull data on the members that are enrolled.
Yeah, I feel like it'd be important to have MODA's data, and that even that wouldn't to the same extent.
Isn't Glenn the primary contact from the OAB staff's side for Weight Watchers?
Pretty sure.
It is Glenn and myself. We tag team. So I do a lot of follow-up with them as well.
And is it your sense that what OAB does is what PEB is this one where we should be in sync?
I would agree. This is a great opportunity to partner.
We want to reach out to Dr. Montner then again as well on this one.
I mean, I think this is, our consultant meeting with our plans, and it means if it's PEB and OAB, it means the three, Providence, Kaiser Permanente, and MODA, having some, at least understanding what type of presentation you will bring to us at SEOW, and being able to make sure that we have PEB participation at SEOW when we discuss it will be very helpful.
Now, can entities have Weight Watchers outside of the health plan? So is there also a membership base we need to be thinking about that's not tied into the health plan?
Well, so for the PEB and OAB benefit for Weight Watchers, you have to be enrolled in a medical plan to access the benefit. That's not to say that someone who's not enrolled in a plan couldn't go for one of their retail products. But to get the PEB OAB coverage for Weight Watchers, it's tied to medical plan enrollment.
Thanks, Martha.
Which is an argument for taking it outside of the premium to make it. We think it's worthwhile, we would want it to be more profitable.
Greg, I see you. Maybe you can unmute, and I assume this is something that is meaningful for PEB.
Yeah, actually, the doula, this holistic, and we all chatted about it in our last meeting. And yes, we are kind of mulling over all of these as well. And yeah, I think putting it to, since we're going to do, I think both of us doing that, it would be good if we were to look at that together. And Dr. Milner is very good at that. I appreciate all the input that he always gives.
Thank you.
So should it then go to IWG?
Well, it doesn't have to. I mean, because the doula thing is it seems that the role of the innovation work group versus SEOW always was a little murky. And because SEOW was only approaching the OAB issues, and it was when we had two different consultants, and now we have one consultant, for both OEB and PEB, and it makes sense for us wherever the issues are important for both. This is kind of an operational thing. I don't know if it falls under the innovation. It could. I mean,
Actually,
it seems that.
keep it at SEOW.
Yeah, I think keeping it at SEOW because it is already part of our, we have to come up with a conclusion of what we're going to do with WW. Because it's, and I think same with PEP. Now we're keeping Weight Watchers going for an additional year. Was that the decision for PEP? And but on a 1-year type of basis.
It's a little PEP specified.
Yeah, so to be clear, so the PEB board hasn't made final decisions
Yeah.
yet for the next plan year, but the recommendation is generally I believe is
Yes.
at this point status quo
Yeah.
for the next renewal.
And is it part of built into the premium for PEP as compared to what our recommendation for?
PEB, we do an invoice, and for the self-insured plans in particular, it's an invoice process. And so I think it like Erica confirmed on the self-insured, it comes through on the claims funding, the weekly claims. I think the Weight Watchers costs are added. It doesn't go, yeah, it's added to the claims.
Okay,
But it's not billed as a claim.
got it.
So yeah.
I understand. Okay. So did we answer what we're going to do with Weight Watchers or?
Yeah, absolutely, and we can touch on timing when we get to the next item, which is how do we want to move all the pieces around to make it, optimize our story for next year. So then the next item related to this, we'll go all the way on the other end of the spectrum, is what does OEB want to do about weight loss drug coverage? PEB will also need to make a similar decision at some point, but this is specifically an OEB would need to make this decision and either develop some talking points for why we're not at the certain point, or look at what does it, what would a rollout look like. So this talks about, there's a clinical aspect to this conversation. There's a carrier alignment aspect to this conversation. There's absolutely a financial aspect to this conversation as well. But this item to me seems more of like a work group type scenario, but open to everybody's feedback too.
Comments from the plans, the carriers?
I think you're going to work group. I think too, what I think about is what is our ultimate goal? Is it, reducing weight at any cost? So paying for medication for the member's career, or is it reducing weight, teaching tools, and getting members off of the medications to have the ultimate, goal of decreasing comorbid diseases and risks? But I think a work group, I'd love to participate if I'm invited. Keith, I'm sorry.
Yeah, no, I'm sure. I think a question does come to cost in a cost-constrained environment. How much to do it? I mean, we have determined about 10% of our old members took advantage of Weight Watchers. I would imagine the majority of those folks would be interested in obesity pharmacotherapy if offered. I don't know that, but I mean, it's just not a small number of people.
Yes,
And so
definitely the primary limitation to work through at this point.
Yeah, I mean, so it's just have to be honest about that in a cost-constrained environment. I don't doubt members would like it. I don't know what health outcomes you're going to get with that. Obesity treatment with medicines. I mean, I don't want to sound like a dour, negative person. Prevention of obesity is super important. Obesity after management, somebody's lost 5 or 10% of body weight. Certainly that helps delay diabetes. Certainly that lowers blood pressure, at least temporarily. It lowers cholesterol a little bit temporarily. It improves quality of life. It helps manage mood. But it's not necessarily the same as somebody who's never had the weight to begin with. So same thing, we don't really know what the natural history is very well of obesity. We haven't had enough obesity pharmacotherapy to really know what health outcomes you're improving when you treat somebody with medications. I would anticipate some reduction or delay of diabetes. I would anticipate somewhat lower amount of blood pressure if you're using certain medications. Whether that's really going to translate down the line to lower cancer risks, or cardiovascular disease. I don't know. For that, I'd put my money in blood pressure management with medicines and statins than obesity pharmacotherapy.
I agree with you, Keith, and I think that the comment that you made, Katie, about determining what is the goal, is it using medications in a short term or a short time frame to give members the tools to then sustain the weight loss, or is it, you know, lifelong coverage of these medications essentially? Because I totally agree with you, the long-term outcomes for weight loss treatments, the GLP-1s in particular, isn't there yet. But I think a work group is certainly a route that can be taken with the right stakeholders to talk about what that looks like. I think as it relates to alignment across carriers, it's just important to remember that both Kaiser and MODA have evidence-driven processes through our pharmacy and therapeutics committees. And so while I think we can pursue alignment, certainly it's a known that the clinicians on Kaiser's pharmacy and therapeutics committee and the clinicians on MODA's committee may not come to the exact same conclusion.
Well, and that's an important thing for us to validate. As I've been thinking about how OEB works, is we have never set out what the guidelines should be. You know, it's we deal with coverage, and then the carrier's responsibility is to figure out, you know, through their processes, medical necessity and things like that. Because if someone has a concern about a specific intervention, they don't come to us. They don't. We're not the accountable agency. It's the health plan is the one that has to make those and is required by law to make those decisions. So as we look at I've been, you know, ever since we've been talking about trying consistency across plans, in some situations is very important. An example is I think the doula process is one that it is a process. When we did bariatric surgery, the idea of having one plan offer bariatric surgery and the other one not offering bariatric surgery would have been a huge problem in regards to adverse selection and all these other things that happen. So it's a tough one.
I think the issue of bariatric surgery is a great kind of example, because 15 years ago, I was like, well, that's not a commercial benefit, right? It's people can get it, but it's really outside their health insurance. And it turned out that it doesn't, I mean, it's very useful, has amazing metabolic benefits. The long-term outcomes have been really quite good. It's not without complications and not without risk, but it's turned out that it's very appropriate benefit. People get that through their health insurance.
And that's a dimension worth considering. So if we are already covering bariatrics, right, that's one of the valid, more aggressive treatment options. But then if we do have an alternative valid treatment options based on clinical guidelines, then, you know, how do we balance that? And then I would also suggest that this work group looks more holistically, not just obesity, but obesity with the diabetes, for a couple reasons. One, because of the strong progression and the intersection around this cardiometabolic syndrome, but from a practical perspective as well. Because if you look again, starting from the recommended treatment guidelines down to our policies and coverage determination, if you really drill down, we will probably find a good overlap of those that are obese with coexisting diabetes. They didn't get there like that, right? So if we look at individuals over time, there's that, while they're obese now with no diabetes, they have the diabetic complications, which gets them covered for the same GLP medications under diabetes indications. So is it a delay? So we have to model this out looking at the population, right? So did we delay the eventual use of medication by 5 years because there's a strong progression of these individuals, if left on their own, untreated, to eventually become the diabetics with the obesity. So I think there's multi factors that we just want to consider through. And I think with some of your data, that should give us some better longitudinal insight about how this will transpire over time and get the alignment of coverage.
So we're talking another work group.
Yeah, I think so. And it might be that one of the outcomes makes me think a little bit of the PRP conversation too, which is whenever we look at these innovative therapies, you know, we're asking these questions at this point in time with the data that's available at this point in time. You know, we come to the decision, maybe not this year. Then the second question naturally arises, which is, okay, when next? Do we talk about it?
What are we looking for? It's almost for us to make a change. What is the evidence that allows us to be able to say, yes, it has now reached the again, nothing is ever completely certain, but we've reached a level of evidence that we think that the cost benefit relationship is such that it's worth it.
Tom Gray has a question on the PEP side.
Yes. Yes.
No,
sorry.
No, real
Thanks, Greg.
Kind of where we were. We did discuss the same as the short-term and long-term. This is something people are going to take forever. But a couple of things that came up with us was doing this for the first year, maybe as a certain BMI to try to get some data on if this really works. And if it's, I mean, we know it does, but you know, for us here. And another thing that we thought was, that we did discuss was, you know, we do have the surgery, but if someone's on that line of getting the surgery, sometimes, and I'm not gonna lie, sometimes I've talked to individuals that the doctor says, well, you're not heavy enough to get the surgery and they want the surgery. Well, we have other ways that may help them get where they're needing to go without surgery. Those are some things we thought that may, in this first year or, you know, first and a half year, try to gather some data, go with, you know, like a higher BMI for the individuals that actually get these as a covered thing to kind of give us some of that. And so that's, you know, don't hold me to all of it, but that's, it's been a couple of weeks since we had our meeting, but that's kind of where I am at. So what I do remember us chatting about.
Now, I think those are the conversations, Greg. Those are the important ones. Jeff?
So what I'm concluding from all this is we come out of a culture in the back that we avoided pills, you know, just take a pill to solve your problem, or premature surgery to solve a problem that should be handled a different way. But we should be identifying the constellation of approaches and the appropriateness of those. And so to some degree, we need to make information available to the people we represent and say, you know, kind of like what the presentation was on mental health. In this situation, this is the avenue that you're helped to identify. I'm saying this in a choppy fashion, but not looking for one size to fit all, looking for appropriate and empirically validated approaches and helping our members understand which is appropriate in which situation, or, you know, there may be some overlap.
And there is one small tentacle from this conversation, which goes back to the previous one, which is all of these works best when it's integrated with intensive lifestyle changes. So as we look at what's available, Weight Watcher Plus, to make sure that there's alignment that says, you know, if those who may end up doing this can still finish the rest of their approach to optimizing their health.
Because obesity or excessive weight, not only you can be obese and not have diabetes, but you're probably wearing out your knees and hips. You know, so I mean, there's all this interconnectivity that goes.
I think a little wider, and maybe this is covering listening to everybody here, but you know, studying economics is the study of human behavior, not finance, like a lot of people think, right? But we're looking at human behavior here. So the problem that I see is that, okay, you get these great results right off the bat, but then we yo-yo up and down, right? And that's the whole, what we're looking for is long-term reduction in BMI over time that changes that. And so I bring up one concept that is kind of expanding on everything that we're talking about here, which is if you look at credit card or financial trouble that people get themselves into, and the typical textbook professor will tell you, take your highest interest rate card and start paying it down. But in reality, if you want to get that person on long term, you'll take the lowest dollar one and pay them off because they start seeing success. Yes. And once they start feeling like, oh, I'm paying them off, they actually get better long-term results than if you do what the financial professor says to do, which actually then puts them right back into financial trouble a year later. Right? So when I look at these combination of things, what I'm looking for is a combination of things that gets that person motivated with maybe some of these new drugs right off the bat for a short period of time, and they start feeling, hey, this is actually good. I should get into the long-term weight. I should be more motivated by doing some of these things, but getting that combination plan together to get the human behavior results that we're looking for. And looking at it from again, human studies of economics, how people behave, what they do. People need to feel something right away to really stick it out. And that's how we want to look at it. Because for me, the long-term goal is and I'm going by what Tom teaches me all the time, which is we don't have a lot of great data, but BMI is one of them that we do know, right? So we want that not to do this. We want that to do this over a longer period of time, and how we combine different treatments, right? To the person who just doesn't want to go in and get bariatric surgery, because that's boom, right? But how do we do that to get them into that behavioral model that we're hoping for? Done.
Yeah, we talked about one of the ways to limit it was in our previous conversations a month or two ago was, do you have the drug benefit for people BMI of 40 or higher, when the probability is that the better option if you're at that point is to have surgery. And then as you start dropping below it, then the numbers start increasing. Very complex problem. We are not able to solve that here. That's for sure. But we do have extremely talented people who represent entities here that can work together. So this is another one of those. And Kirsten, you've talked about, this is not one that, this is one that we don't put it all together by 2024. It actually, having a multi-year approach is one that is helpful. So the idea of having a foundation, understanding that foundation around what lifestyle changes work. That was our conversation about WW, and then talking about this, as Jeff is saying, these multi-layered approaches. I like the idea of how do you come up with success. The idea of $15,000 a year drugs that go on for the next 10, 15 years, that's an issue. So we'll ask Mercer to pull together again the carriers on this one and look at. Now, in terms of time, we had talked about maybe looking at SEOW's work plan for next year. I'm going to put that on hold. We'll do that again in probably in June, because I do want to spend time talking about the dental clinical performance measures. That's one that it would be nice to have in place for us to move forward to bring to the board for approval for the next plan. So
I would like to just dot an I.
Do, please.
And that is mentioning information and helping people make appropriate decisions. An example is bariatric surgery sounds like you're kind of one and done, but I'm not sure that enough conversation occurs to what is after bariatric surgery. And that's why I think information really needs to be a large part.
Right.
Done.
Agreed. Agreed.
Yes,
Okay. Okay. So SEOW members feel okay with us moving forward? Yep. Consultant,
Yes,
are we
okay.
ready? Super. Okay. Do we have some Terry? You want to come up?
From KP, I have Dr. Hillstrom who may be calling in.
Oh, good.
Yeah.
Okay, great.
Dr. Chambers from Willamette Dental is
Okay.
on the line as well.
Great.
Probably from the team.
Great. Okay, wonderful. And Mark, are you there?
I am here.
Great, thank you. Terry. And Dan, are you on yet?
Dan's meeting hopping, but we let him know, so he'll be joining soon.
Okay, all right. So Kirsten, you're on.
Yeah, great. So the idea here, this has been a work in progress with the dental clinical metrics. So we talked last month about adding a new dental clinical metric to the portfolio. So now we have 3. Can you go to that slide, Maggie, please? So now we have 3 clinical metrics we'll be looking at: preventive service utilization for adults, for children, and then adding oral evaluation for adults with diabetes. With all 3 of those, we want to have a conversation with everybody here in the room together about what the targets would be and setting targets. So what would year 1 be? How could the target vary by carrier? Because carriers might have different levels of information available, right? So we can have the targets vary by carrier, but then actually putting in place targets for the upcoming year. I don't think we have to decide now how they will evolve over time, but we do have to have an understanding of the fact that they will evolve over time, right? And as we head towards some kind of result that we're going. So we just had a couple notes there just to get the conversation started. But that's where we wanted the dental clinicians to weigh in, for the carriers that they represent and offer some ideas, and we could all have that conversation together. So Dr. Barrichello, you want to start?
Yeah, sure. So a couple of things come to mind, and I definitely want Nathan to weigh in because, primarily I feel like the clinical opinion really matters on what types of measures, but definitely then the data piece, there's some elements that we have to be really mindful of. A couple things come to mind as we look at Delta Dental. Historically, our performance on the preventive service utilization is really, really high. So looking for improvement targets may not be the right goal for our plan. So I like that looking below at the targets varying by carrier, I think makes sense. And ours may be more of a maintenance measure. And another thing that comes to mind is looking at, and I don't know all of the methodology behind how you're looking to calculate the measure, but looking at continuously enrolled members, because there's a lot of noise in whether we're counting a member that's been enrolled at any one particular time or whether someone has been continuously enrolled. And I think there's a lot more, I think it's more meaningful to go after those members that are continuously enrolled. And you can probably speak maybe a little bit more to that.
Yeah, absolutely. And so I think looking at continuous enrollment in particular, one of the areas that I think is going to be even more challenging for the oral evaluation with diabetes is thinking about the combination of medical and dental coverage. So if we're looking at, are they continuously enrolled on the dental plan to gather that oral evaluation piece, but then thinking about how are we identifying the medical coverage to determine whether or not they have diabetes, and then just kind of tracking and logistically managing all the different data sharing opportunities there as members move between different dental plans and different medical plans as well. So I think that the logistics around this is going to get to be a little bit tricky when we start thinking about calculating the metric. I mean, OHA published some specifications for the metric. They're relatively straightforward. They do include continuous enrollment evaluation, but as we start trying to think about how we track movement across all the different carriers, that's going to really apply a lot of challenges for us from a data sharing perspective, and then as well as kind of setting benchmarks and then trends I did pull just a little bit of data on the members that we have today. For OEB, we've got about 80% of the adult members have MOTA coverage with the Delta Dental coverage. On the PEB side, it's about 18%. And so as we start sharing some of that data on the PEB side in particular, there's going to be a lot more unknown for those members that, you know, there's a lot of members that will have diabetes. The Delta Dental doesn't know about that on the PEB side. There'll be less so on the OEB side, but there's still a lot of opportunity even within that 20% for things to shift. So I think being able to report the data that the carriers have together is going to be, or sorry, individually is going to be one element that we can report today. But as we start thinking about how do we collaborate between the different carriers to set, you know, an appropriate benchmark for the whole population, that's going to be a different conversation. I don't know that we're really at a place where we can say, you know, this number is where we think we need to be. I think we need to be looking really more at a process of how we can share some of this data, and then we can use that initial reporting period to really look at where are we at, and then what sort of benchmarks do we get to. I think it's just too early to really say what you know, if we were to just look at a number, it's the data that we have on hand is not going to be really reflective of the population's performance as a whole.
And so the challenge, all the providers are able to answer number 1 and number 2. It's number 3 that's complicated. Dan, my guess is that there's relatively majority of people who have dental, have KP Dental, have KP Medical. And Mark, no one in your group has Willamette Dental Medical because it doesn't exist.
Correct.
Yeah. Dan, do you know the number?
Yes. I would say like 80%.
Yeah. Okay. So for OEB at least, not PEB, but for OEB, the communication between, and I assume there are no hurdles for Delta Dental to talk with MOTA Medical to understand who has diabetes.
Correct. We have that all data in the same
Okay,
data warehouse.
and I assume the same thing is for Kaiser Permanente, no problem. Kaiser Dental talking with Kaiser Medical to get that type of information. Okay. And so then the process piece, Mark, have you thought about how your group would try to get information on members with their diabetes? Is it just by asking them?
Well, you know, we do have a fairly robust, you know, health history and EHR that reports that. And so we could go off and self-report. And I think that would be the easiest way for our group to do that.
Does the average American know the connection between teeth and diabetes?
But
I know eyes, I know.
But they know that they have diabetes.
I know, but they don't. I didn't ever until I'm working here.
Yeah.
Think about teeth and diabetes. I always do eyes, feet, digestive. I've never thought of teeth until I started doing this.
Well, but it's the dentist's responsibility, the dental provider's responsibility to make that association and to do the education.
That's the education part. Because if I'm sitting to my dentist, I'm not telling my doctor, because I don't even think about telling him that I have diabetes. It doesn't pop in my head. Right.
I'll say, can I, if I might, I'll just say I like, you know, Dr. Chambers' suggestion. I think it makes the most sense. Is I'm sure I know Willamette has risk assessment tools that they use, and diabetes is part of any type of risk assessment around periodontal disease. So I'm sure that they have, and you guys have that system. You can report on that. And self-reporting, I think, is fine. And it is really a standard part of any health history intake of any dentist if they have diabetes as well as their medications. So, because it does impact the care depending on what the care looks like. So I think there's a path forward to do that. And I don't know who said it in the room about benchmarking. That makes a lot of sense. I think also, you know, the preventative services for adults, there is no OHA measure on that. That's a new one, okay? Now, Dr. Bertrelli talked about how they have really high rates. which is very kind of the community standard. Everyone comes in every 6 months. But Kaiser, and I would guess Willamette too, look at that very differently, because you don't need to get your teeth cleaned every 6 months if you're healthy. And so you're going to see big differences in those preventative services among adults especially. Children, we're going to have a higher rate, and I think most carriers agree that children need to be seen more frequently. But I do really think having an approach where I think following what the OHA has outlined is a good process, because all of us are already measuring that, and we have those processes in place to look at it. Adults is a new one. We measure that in our program. And I think splitting it up between Delta and Willamette Kaiser and setting different, at least benchmarking it and understanding that there's going to be differences there is a great start. So I'm all supportive of that.
An idea that was raised during one of the scoping conversations was having potentially this metric would vary by risk to the extent that some sort of health risk assessment was being done, to address your concern, Dr. Pilstrom, about, well, if you're low risk, we're going to recommend an exam at a different frequency. That's still us being successful, but our metric is going to look lower. So I think one idea that was circulated, maybe it was Kaiser suggested it actually, was should this metric vary by risk? In which case we want to make sure we're stratifying the risk of our member. Maybe that goes along with when we're asking them if they have diabetes. And then based on that risk, somehow we have to track it. Then the metric is going to vary by where you are in that.
So yeah, and I think that we could do that. And my guess is Willamette, and both Willamette and Kaiser, I know, have systems, at least within our own systems, we have standard risk assessment tools. And the evidence shows that kind of any kind of risk assessment tool you use kind of works. They all kind of work. Now, there might be slight differences in how people are risk assessed, but between low, moderate, and high risk, I think there's a lot of congruence between the different systems, even though they're different. They tend to risk people correctly. It does create a little bit more complexity. I would say I like it in the sense of, to me, it's the right approach. Delta is not going to, correct me if I'm wrong, Terry, but Delta is not going to have that just because different providers don't necessarily use a risk assessment, formal risk assessment tool, and they may not have a way of inputting data on the risk of those members. So, you know, that's the challenge there, but it's all workable as long as you, our partners, kind of understand the differences and variations. And I think we're all trying to get better in seeing the patients correctly. It's just a matter of putting together and formally reporting out on it.
Yeah, go ahead, Mark.
I was going to chime in real quick. You know, Dr. Filstrom talked about utilization and risk assessments, and you know that becomes really important because when we look at the dollars that you are spending on your employees for dental care, we want to make sure that those dollars are being used efficiently and effectively, and where we're going to get the best bang for our buck in keeping our patients healthy. And that's the ultimate goal. We want increased health for our patients. And Dr. Filstrom talked about, you know, that 6-month cleaning really doesn't do a whole lot for that patient that has impeccable home care and healthy gum tissue and good bone level support and doesn't have risk factors like diabetes and that. However, we do want to have that patient that does that periodontal disease come in every 3 or 4 months for periodontal maintenance after they've done scaling root planing. So it really needs to be kind of targeted towards those that need it the most.
So when I'm hearing, go ahead, Nathan, then I've got a comment.
Okay, yeah, I had just 2 quick comments. The first one was around some of the risk adjustment and some of the challenges. You know, we have a really broad panel, and dentists are going to be collecting risk in different ways, and then they have different levels of ability to report that back to us. So to do a risk-adjusted metric for us is going to be technically very kind of challenging as we try to merge all those pieces together. So there's a data management aspect. The other piece that I would say is that looking at some of my experience with the medical development of quality metrics. Using a risk-adjusted process adds an extreme layer of complexity to just how we do the calculation. And so my recommendation is really, how do we start in a very simple way? What can we report? What data do we have available? And then look at kind of iterating and adjusting over time, so we can at least kind of move something forward and get a little bit of an idea of which direction we want to try to go, without trying to really get it engineered to a really kind of perfect level, where we can at least start to see some progress.
So I'm going to give a recommendation and we'll see whether or not it's acceptable. And it varies by carrier. So Delta Dental reports number 1 and number 2 for their entire population. Willamette Dental and Kaiser Dental does 2 different populations, low risk and people who are medium, high, highest, whatever, but basically divide them into 2 groups, low risk and this, I'm sorry, for the adults. I think for the children, my understanding is that we keep that as one population for children, and for adults, it's low risk and higher than low risk, and have you report out on that. And the issue around diabetes, the diabetes measure, it will the Willamette will use self-reported. And Dan, you can decide whether or not you're going to do the self-reported versus, you have it in your electronic system.
We'll use the medical data.
Okay, and Delta Dental will use the population that has also MODA medical. And I think that gets us to where we're able to be reporting these 3 measures, and it addresses the issue of Willamette Dental and Kaiser Dental around whether or not, because of the different type of system for the prevention for adults. Is that a fair? Have we split the baby in the appropriate parts?
So Tom, for the target then, would it just be prior plan year actual? And that way each carrier is starting from their benchmark for the actual target?
I think what can happen actually is that you can look back. The problem, of course, is the crater that we had with COVID. And so from a historical standpoint, it'd be interesting to know what plan year, what 2019 looked. But from my perspective, I'm fine with going current and forward. And I think what we have is we're going to have then a conversation around what the targets should be. I would, what I'm hearing from Delta Dental, Terry specifically, is saying, we think that actually maintenance of where we are now is appropriate for where you're at. Very well possible. I haven't heard from Mark or Dan what, if you were going to, what targets you would choose.
I need to look at the data on those. Actually, we measure adults by plan. And I don't know at the top of my head what our preventative services for adults for this group is, but I have to look at how it's split up by risk. But I think there's for us, I just think looking at the data at the different carriers and coming to an agreement on, and here's the other thing I'll point to is, do we have to have a target individually, or do we benchmark improvement for each if improvement is thought to be needed? Those are really hard questions to ask. Versus like, hey, Willamette and Kaiser, your goal is 50%. Maybe it's an incremental improvement of X over a benchmark year.
Yeah. I'd be interested in, because the nature of the practice is pretty similar, I would like Mark and Dan to talk with, between the two groups and come up with at least what you would jointly agree to as what we would do with targets over time. And you can spend a little time and get the data. Maybe you can bring that to us in June at our June SEOW meeting. That would give you time to look at, to do that differential between low and higher than low risk, and use whatever data you want, but give us a recommendation that you two would do jointly.
I think that sounds great.
Yep.
Now I'm just kind of free flowing here. So, I want to give my colleagues a chance to jump in. Reasonable? Yeah. And for Delta Dental, again, address the issue of do you, if you think you're at the very best that you are now.
We can provide a historical look back for adults. And I do want to point out too, because the 2 cleanings a year is sort of, I think, a red herring in this conversation, because the preventive service utilization metric and the performance that I'm referencing is exactly 1 per year. So the performance and I that we've done year over year quite well is 1 per year. So I just want to clear that up.
I remember your numbers.
So the plan design is kind of irrelevant to this conversation. I just want to point that out.
But what you're, part of the problem is that with the insurance part is that if the coverage, it has to be within a year. It is a calendar year that we've decided that we're landing in. So the advantage of calendar year is that if you had service in January of 2023 and had service then December 2024, you're good. So that gets out of the bind of if someone, within a 12-month period of time. So that helps that part. What was I thinking? Yeah, so we'll think about it. Again, challenge your assumptions about whether or not your goal is to just maintain versus to have some stretch or.
One thing I'm wondering about, when we talked about principles of metric design last month or the month prior, we agreed that as we evaluate clinical current metrics and ask, should be this taken forward to the next reporting period? One of our criteria was, is this metric providing valuable information? Is it driving the carriers towards a meaningful improvement in an area that needs improvement? So I'm wondering, if the dental adult utilization metric for MODA or for Delta Dental is already at its optimal level, and I know we haven't agreed on that, but if it is, I'm wondering if it's an opportunity to bring in a health equity lens to the conversation and say, but is it optimal for every different group within your overall population?
Right.
And that way, we're still getting value.
That'd be very great.
Also, I think there's some question as to whether, there's been a rebound to the right level post-pandemic too. I think the jury's still out on that. So I think that's something that we need to understand.
We can definitely look at the trend data that we have there and address that question. On the health equity piece, I think that's an excellent idea. And we'll have to look at what data we have, and particularly how far we head back on that to really address trend and then kind of get to benchmarks. But that's definitely something we can take a deeper dive in.
We were trying to get to this level of detail in our conversation at about February 2020. I remember. This has been a journey that got interrupted. So I'm glad that we're back on the path. We didn't have to nail everything down today, but we needed to come up with what direction we're going to go.
Doesn't the COVID excuse expire next July 1st?
May 11th.
I think, I don't know when it does. Yeah, no, there's profound changes that are still occurring. We are not done. Okay, did I summarize well enough for where we're going? Great. Thank you very much. So if we could have in June, maybe just a 10-minute, I'm sorry, it won't be, it would be from Mark and Dan, kind of the agreement that you two have been able to work out in terms of what you're thinking of in terms of improvement over time, and that each of you will get hopefully be able to get the data of what your 2022 baseline is. And it's fine. I don't know whether, for HEDIS, because of HEDIS, we've used, even though our plan year is October through September, we use a calendar year because that's how medical data comes in. I don't remember what we've done with dental, whether or not we've used plan year or calendar year.
It's been plan year.
Yeah. Okay. If that's not a problem, if we've used plan year, if we can continue with plan year. Mark and Dan, is that okay? You can cut that way?
I think we're flexible. We can make either work.
Okay, so if you can give us your base, I'd like to see baseline for this stuff, the measures by the June meeting. That gives you 2 months for the 3 measures baseline. And if you want to do historical, that's fine. The problem is there's the last 2 or 3 year crater, and I don't think that's going to help us.
Right. Agreed.
All right.
And can I ask a question? So for children, do you have those ages sorted out? Maybe I missed that email. Is it the same as the OHA ones, or does a child go up to 18? Is there 2 different groups, just all together? Probably should know that, but
I don't know.
All right, think about that.
I think we've been reporting these metrics before and have some set specifications. Off the top of my head, I don't remember exactly what they are, but we can look at what we've been reporting. For the first 2.
Nathan, can you send that then to Sapari and Erica, and they will get them, to Tiffany. You can get it to Tiffany and to Sapari, and then they'll get it to your clinical people.
Not a problem.
Super. Thanks. All right. Thank you. I think we are done with a couple 10 minutes early.
Good. Thank you.
Yeah. Thank you.
Somebody say lunch.